and I want to talk about rational design, really, of drug carriers and that are equally applicable to contrast agent carriers also. Before I get much further, talk about the people who are really doing the work as opposed to talking about it. I have 6 students right now at CSU, and with Ravi Bellamkonda, who's just been hired by this department, I share 3 students. Ivan Vesely's group, and I'm not really going to talk about this work today, at Heart Valve Evolution. And with Eric Hoffman's group at the University of Iowa, and there's a long list that goes below this, but these are my primary collaborators. Ken Beck is a radiologist. Jeff McLennan is a pulmonologist. Interests in my group are quite wide. I have an extensive project on computational fluid dynamics simulations of the lung. And what we do here is we take CT scan images of the lung geometry and perform simulations on those, with the idea being that the geometry is actually critical for the delivery of inhaled drugs to the lung. We've just published this work in ABME showing that the geometry is actually the critical determining factor. And the proposal that we have is to be able to do patient-specific CT scans or some other imaging modality and use that to optimize the drug delivery for a given patient. So clinically now you see up to 100% variation, all else remaining the same simply based on geometry, and we hope to be able to reduce that in respiratory drug delivery. Another section of my group, and both these things I'm not really going to talk about in any detail today, I'm just giving you a quick overview now. We look at fabricating controlled and modulated release particles for delivery of drug to the lung. And the target that we have here is for insulin, for example, to be able to establish a week-long supply of insulin in the lung and then trigger the release as needed for systemic release into the body. And the way we do this is we have nanoparticles which we cross-link to form these large cross-linked agglomerates. The insulin or whatever drug of choice is contained within each of the nanoparticles, and then you expose internal surface area by introducing a cleaving agent. We've done this for insulin, we've done this for ciprofloxacin, but that's a topic for a different seminar altogether. What I'm going to talk about today, or what I have down here, we've applied many of the drug delivery concepts that we have working to the delivery of contrast agents. It turns out that in CT contrast, for example, the last significant development was 30 years ago with the development of non-ionic contrast agents. There are huge shortcomings to their use, and I will discuss that. And I'll talk about what we're doing to improve the delivery of contrast agents. This work was just recently accepted in academic radiology. It should come out in the next couple of months. And I'll talk about targeting of these carriers using ligand-based targeting technologies that we've also been developing in my lab in collaboration with Ravi Bellamkonda. Okay. What are the issues today with iodinated contrast? One of the big problems is osmolarity. It turns out that clinically relevant contrast with iodine requires something on the order of 600 milligrams per kilogram of iodine. And iodine by itself elementally is highly toxic, so you have to work with some compound of the iodine. These need to be highly soluble in aqueous medium in order to be able to image the blood pool, for example. And by the time you get this much iodine into solution, the osmolality of the solution is huge and is going to cause all kinds of other problems when you introduce it into the blood. One approach is to simply reduce the total number of of molecules that are carrying the iodine atoms. And what people have done is go to non-ionic materials versus ionic materials. And the idea being the non-ionic materials do not dissociate So one molecule that contains iodine is going to remain as one molecule, and therefore the osmolality would potentially be 50% of the case where this dissociated into two species. And a classic example of that is iohexol, which we actually use in a lot of our work. And it has 50% of the osmolality of a similar compound, ditrizoate. The second approach has been to simply increase the number of iodine atoms per molecule, and there's been a relatively recent development, Visipake, which has 6 iodine atoms versus 3 in the case of iohexol. And I think in the next couple slides I show their structures. Yeah. Okay, so here is iohexol. Again, it is a non-ionic contrast agent. It's got 3 iodine atoms per molecule versus Visipake, the newer material, which has 6 iodine atoms per molecule. So conceptually, if you got these both with the same molar solubility, you would have twice the number of iodine atoms in the solution versus this at the same osmolality. Okay, so that's one approach that people have used. The other approach they've used is look at atoms other than iodine as X-ray absorbing agents. Gadolinium and dysprosium are 2 examples. And what I've shown here is essentially the absorption coefficient getting close to the K edge as a function of energy. And I've plotted here 90 keVs to about 150 keVs, which is pretty normal for CT scan instruments. And what you can see is there's about 1.5 to 2 times, depending on how you look at it, increase in the absorption over iodine in the case of gadolinium and dysprosium. And gadolinium and dysprosium have advantages because they could potentially also be used for MR appropriately applied. So that's another approach that, that people have used. In all these cases, however, there's a timing constraint. And what I've shown here, this is data from Bay's group at Washington University. All these small molecules are going to clear very rapidly from the circulation via the kidneys. And what I'm showing here is the enhancement in Hounsfield units as a function of time post-injection for a typical iodinated compound. I think this was actually iohexol that they used. And what you're seeing here is a very rapid rise in the contrast, up to about 300 or so Hounsfield units, and then a rapid drop-off down to virtually noise levels. And this is using a injection in the superior vena cava. So if you wanted to image the heart, for example, you would inject this material immediately upstream of the heart. So you'd have to do a catheterization procedure, inject the material directly upstream of the heart, and then the peak enhancement you get is only about 50 or so seconds wide. And if you want, even within this 50 seconds, there's this very rapid rise and fall. If you want stable contrast, you're essentially relegated to noise. Now, there are ways of making this better by mechanical means. And one approach has been to simply slow down the injection. Earlier, I talked about a 5 mil per second injection. If you slow it down to 2.5 mils per second, then you can broaden and smear out that peak a little bit. But this is still a very, very difficult image acquisition procedure to do because you've got to time the image acquisition to this peak. And so the injection is performed, I don't know how many of you are familiar with this, but with a high pressure compressed air type injector. A certain percentage of these patients end up having failures in the injector and blowing out the blood vessel where you're injecting it. It's a risk-fraught procedure. Now you can slow this down further by doing a biphasic injection. And so we're still talking about 100 seconds or so, and now of suboptimal contrast. So what we'd really like to be able to do is take this to the next level and see if we can extend this period quite significantly. Some of the other problems that go on with the current CT contrast agents, in order to get these high contrast levels with high iodine concentrations, you end up with very, very high viscosity. So now you have to inject at high speed in bolus, in a catheter, something that has very high viscosity. These things clear via the kidneys. There's toxicity associated with that, high-speed data acquisition that I talked about. It's very difficult to time scans during that peak enhancement. So you synchronize the scanner with the bolus injector. And a sizable percentage of the time, you miss the peak and you don't image the blood vessels that you want. Many times you have to work with multiple maneuvers, so you have to inject repeatedly. And the iodine loads that you're injecting into the body are huge. And as a result, you can't really use these techniques if you've got renal dysfunction already or if you're diabetic. The material is contraindicated. So we'd like to get to a state, just to cut to the chase, where we have a T-half for a clearance that is greater than 6 hours and try and eliminate a lot of the toxicity problems. We want to see if we can clear the stuff differently instead of via the kidneys, and we can do that. And we want to look at targeting and so on. Okay, so how do we go about this? Well, it turns out that one way or the other, a lot of things in my lab end up dealing with liposomes because they're very versatile, and everyone in my lab can make liposomes in their sleep. For those of you who are not liposome aficionados, they consist of a bilayer bounded vesicle, and the molecules in the bilayer are typically some mixture of lipids which have a long fatty acid chain and a polar head group. I've shown here a phosphatidylethanolamin example. Typically, the liposomes that we work with also have 30 to 40% cholesterol in the bilayer for multiple reasons. They increase the rigidity of the bilayer, and also if you go much below about 10% cholesterol, when you inject these things into the bloodstream, they cause hemolysis because they extract the cholesterol from red blood cells. You can make these things in many different structures. You can start them out as multiple layer vesicles, and then through a procedure that I'll show you later on, we actually make these things that are small unilamellar vesicles. Okay, when liposomes were first conceived of, people thought of them as replacements for cells, and the idea was that if you injected these things into the bloodstream, they'd stick around for a long time. Tried it didn't work, because it turns out that liposomes are simply not hydrophilic enough. And they are very rapidly opsonized, and they're cleared. This is a relatively old quote. I kind of like it, which is why I put it up. It turns out that you have to increase the hydrophilicity of the surface of the liposomes in order to enhance their circulation half-life. And I love this line: to be invisible, one must look like water. So if in the body, that's what you need to do in order to be invisible. So these are called stealth liposomes. This is relatively old technology. And this is the basis of a company where I used to work, and we've put a couple products out on the market based on this using doxorubicin, a chemotherapeutic agent. And so the way these work is you've got a bilayer bounded vesicle now with a polyethylene glycol molecule hanging off the side. And this imparts sufficient hydrophilicity that you greatly increase the blood circulation time. As an example of that, here's doxorubicin data that we collected a long time ago. Here's free doxorubicin. So this is the free drug injected into rabbits. They both start out at exactly the same level. And you can see the free drug is very rapidly cleared. This is also renally cleared, by the way. Whereas in stealth liposomes, the clearance is much slower. And you can see even 48 hours after injection, the stuff's still hanging around. Clearly, from a bioavailability perspective, you can see how this would be far superior to the free drug, provided it also got to the tumors, and it turns out it does. There is a dependence of the clearance on size of the liposomes. Here's 100 nanometer liposomes versus 200 and 400 nanometers in time following injection. And you can see very clearly that the smaller these particles are, the longer they take to clear. The trade-off that you have is the smaller these particles get, the more lipid you need per unit volume of encapsulate because of the surface area to volume ratio considerations. So you have to trade that off and you pick particles that are the right size. Okay, so with that introduction to liposomes, and this is how you make them. You self-assemble lipids in aqueous medium. You extrude them through these polycarbonate filters. These are nucleopore filters which have cylindrical pores, so they're not your typical depth filter configuration, but they have cylindrical pores, and they essentially act as extrusion dies, and you can make a fairly tight distribution of sizes. All right, so now here is our data on iohexol. So this is an iodine compound that we have encapsulated in stealth liposomes. We put this in a rabbit. It's 30 mg per mil of iodine was the material that we made. We split the injection up actually into 2 injections that were 15 or 30 seconds apart, so it doesn't really show up on this plot, but you'll see the data later on. Immediately after injection, the X-ray absorption in the blood, so this is aorta, the pulmonary artery, and I'm calling this liver cortex, but it's actually the hepatic artery. It jumps up to about 200 Huntsville units, and then it stays flat for the 3.5 hours that we ran this experiment. At this point, our radiologist friends got bored and they went home because nothing was changing after that. There is a transient rise in the kidney core, and this is primarily because our formulation had actually leaked a little bit before we even injected it. And so the leaked iodine compound behaved like free iodine. And when you correct this for the kidney volume, it turns out it's about 10%, which is almost exactly what had leaked before we injected this. And in less perfused tissues, you don't get nearly as much of an increase. That's because there isn't enough blood here for us to see a significant increase in the contrast. Okay, so this one is without contrast, this is with contrast. And you can see all kinds of details in here. This is a very coarse image. I'll show you a lot more details later on. But you can start seeing the heart. You can see carotids and jugulars and so on. And it turns out you can also start seeing vascularization of the bowel. And so anywhere where the blood goes, and by the way, this is 2.5 hours after injection of the contrast agent. We can see the blood vessels very, very nicely. Okay, so here is a cross-section through the heart of that rabbit. This is before contrast injection. You can't see much. This is after the injection of the first dose of contrast, and you can start beginning to see some features developing in the heart. Here's after the second dose of contrast injection, and now things are lit up very nicely. You can start seeing various heart chambers. You can actually start seeing even a coronary artery, and I'll show you that a little later on. And here is 2.5 hours later. The rabbit moved a little bit, but the image is static. It's exactly the same as it was when we first injected the contrast agent. Every time I show this to a radiologist, their jaws drop. And they say, oh, how did you do that? And well, the answer is the stuff just sticks around long enough in the bloodstream. Here is the liver before injection of the contrast, injection of the first dose of the contrast, and you can start seeing quite a few blood vessels. Second dose of contrast, and now things are really very well lit up. And again, 2.5 hours later, things are still lit up just fine. Here is image of the heart. This is a volume rendered image of the heart chambers. Before contrast, obviously, you can't see anything. After contrast, you can see the aorta. You can start seeing the pulmonary artery, left ventricle, right ventricle, inferior vena cava. You can even start seeing valvular details, and I'll show you a thick slab rendering that will pick out the valve details for you. Okay, here, it turns out in our rabbit model, 100% of the time we can pick up the coronary artery, not a big deal. Whereas traditionally, I'm told in humans with bolus tracking of the injection, you're lucky if you pick up the coronary artery 15 or 20% of the time. We don't have that problem because there is no bolus tracking. You don't have to worry about chasing the bolus right through the coronary. We can pick it up 100% of the time with no problems, even in rabbits. Considering, of course, that the rabbit coronary artery is a lot smaller than the human coronary artery. Here's the thick slab rendering I was telling you about. So this is a 2.6 millimeter thick slab, and we can see the septum, different chambers, and we can start seeing the valve plane here, and it's equivalently displayed here also. This is again 3.5 hours after injection of the contrast agent. So essentially where we're at is with our contrast agent, you don't need any timing. And you don't have renal toxicity. I didn't talk about that a lot here, but it turns out liposomes clear via the liver and the feces. And so you can use this even if renal toxicity is a problem for a given patient because you don't send the agent to the kidneys at all. The next thing that we started looking at was what can we do beyond the blood pool? Can we image tumors? And it turns out that there is a wealth of literature on the localization of liposomes to tumors. They've been around for a long time. And the pharmacokinetics for the transport of liposomes from the blood compartment into intratumoral capillaries, and for the localization of the liposomes in the interstitial volume, these are very, very well-known numbers. And you can clearly see, and the clearance numbers are also very well known. And you can clearly see that because this is one directional, you're going to get a continuous accumulation of liposomes into the interstitial volume of the tumor. And therefore, one would expect that the tumors would light up very nicely over the blood pool. And that's exactly what we get when we simulate this model. So here's the blood levels in Huntsfield units again. And here's the prediction for what happens in a tumor that is undergoing angiogenesis, which means extravasation of the liposomes is going to be a possibility. And so 2 or 3 hours post-injection, you can clearly see that the tumor is going to be lit up substantially over the blood pool. And this has huge implications for early detection because what this means is any tumor where angiogenesis is taking place is going to be targetable by a liposomal contrast agent. How soon do tumors start undergoing angiogenesis when they're starting to grow? Well, we started measuring that. There's also literature data on it. So this is a histology slice through one of our tumor models. So here's a C6 glioma in a rat brain. And this is 9 days after injection. It's grown quite nicely. But as early as 2 days post-injection, this is a factor VIII stain, you can start seeing factor VIII present on the inside of the blood vessels. This is 4 days, this is 9 days. And so we're very confident that very soon after angiogenesis begins, and that might happen even 2 days after implantation of these tumors, for example, that we'd be able to pick them up. So the onus now is not on the contrast, but the onus is on the resolution of the CT scanner. And so what we feel is that we can pick up tumors at the size resolution of the CT scanner, no problem. Now, what you're going to do with that once you detect it is another story altogether, because it's not even clear today that even with traditional mammography screening techniques, for example, that therapy is the right thing to do. There's a paradox in breast cancer screening, particularly for women between 30 and 50, for example, where if they were screened, their mortality rate was actually higher than if they weren't screened, and that's because adjuvant chemotherapy was not being used. They simply went after the primaries with surgery, and then the secondary metastases started blooming. So what it comes back to is if we can detect these things at 1.2 millimeter size, it's not clear to me that therapy is ready for that yet, but we can certainly detect them. Okay, so I'm going to change gears a little and stop talking about contrast for a while and start talking more about targeting. because it seems to me that that is the next generation of cancer therapies. We started looking at gliomas fairly early on when we got into this because of a number of reasons, apart from the high incidence. It turns out that gliomas are unique. They're diffuse and they're invasive, but they're also separated from the bloodstream by the blood-brain barrier, the tightly packed cellular lining of the endothelium. This makes treatment of gliomas quite difficult to do, and the most effective drug today, BCNU, is not particularly effective from a cell kill point of view. There are plenty of other chemotherapeutics that are much more effective from a cell kill perspective. BCNU works because it happens to have high blood-brain barrier permeability. So the approach that we were taking was, how can we enhance blood-brain barrier permeability for some other agent that potentially has a higher cell kill rate? As it turned out, we were interested in targeting otherwise for a number of other reasons, and we were looking at ligand receptor-based targeting schemes, and the thought that we had was, let's take our targeted vehicle and add, shall we say, transferrin to the outside of this vehicle and enhance the blood-brain barrier permeability that way. And then, of course, we started thinking about the same things for contrast agents. So I call this a rational approach to ligand targeting. And again, we started out with a liposomal basis for our carriers. And it's been known for quite a while that if you put drugs inside liposomes, and then in order to maintain these things in circulation, you put polyethylene glycol on their outside or whatever other hydrophilicity enhancing agent, you cannot put the targeting ligand directly on the surface of the liposome because it gets clouded by the PEG. You really need to put this targeting ligand at the distal end of the PEGs so that they can match up with the receptors on the cell surface. And so our approach has been to mathematically model the binding and the uptake process. And the idea here is that we can optimize the lengths of these PEG tethers. So if you go back to the previous slide, a question to ask is, how long should this tether at the end of which the ligand is bound? How long does it have to be with respect to the rest of the PEGs? Clearly, this is an extreme case where that length is 0, and we know that's not effective. Is it effective if these tethers are the same length as the surrounding PEGs? Do they have to be longer? How much longer? Those were some of the questions that we were trying to answer, and also try to answer how many of these ligands do we really need in order to have optimal binding. And so we've developed actually a pretty good mathematical model, I think, of this process, and we're at the stage where we're able to fabricate carriers now with different tether lengths and different ligand numbers. We're testing these things in vitro, and we're just to the point where we can start putting these things in vivo. We're running into some practical difficulties there, but it's only a matter of time. There's been actually a lot of literature on the modeling of surface and cell interactions, or surface and carrier interactions. Laufenberger's group has looked, this is relatively old work going back to the early 90s, the binding of multivalent ligands to cell surfaces. Linda Griffith's group has also looked at the simulation of cell surface adhesion. But again, the fundamental difference between these and what we're doing with targeting drug carriers is they're all looking at cell surface adhesion. So they're looking at relatively large cells adhering to even more extensive surfaces. There are a few pieces of work where they're looking at virus attachments to cells, and one article that I've found actually on liposome cell interactions. But the big shortcoming with this is there's only a single interaction considered between the liposome and the cell, which means one ligand bonding to one receptor. And they've also looked at conventional liposomes, so there's no polyethylene glycol coating on their outside, so it's really not very realistic for an in vivo situation. So the the model that we're building is really applicable to stealth liposomes treating tumors. We organize the receptors on the surface of the cell into clusters, and you've got to take those dimensions into account, it turns out, and we'll talk about that a little bit later on. We look at liposomes that have polyethylene glycol for stealth properties and ligands bound to the distal ends of those tethers. Just to position you in size space with all these different species, liposomes that we work with are typically 100, 125 nanometers or so in diameter. The polyethylene glycol coating on the outside of these liposomes is a few nanometers, so that the Flory radius for a 2000 molecular weight polyethylene glycol molecule is on the order of 3.5 nanometers. Cells are 15 microns, so they're huge compared to the liposomes. So for all practical purposes, the cell surface can be considered flat. The cluster sizes, they vary quite a bit, but a typical size is about 70 nanometers. So if you think about it, a liposome sitting on top of a cluster pretty much saturates that cluster. It's very unlikely that a different liposome will ever be able to bind to that same cluster. The number of receptors per cluster, there's a little bit of literature on that, and I've seen numbers varying between 15 and about 40. Okay, so when a liposome or a drug carrier starts approaching the cell surface, what happens? Ligands at the end of these tethers start reaching out and grabbing onto receptors on the surface. The first likelihood of such an event occurring is if this polymer tether reaches its fully extended length. And I'll show you a little later on that this fully extended length is actually quite well defined for different polymers. Once that happens, it pulls the liposome in closer to the surface. The polymer is now a little more relaxed, but still, at this binding distance, there's a limiting number of ligands on the surface of the liposome that can really bind. So you fabricate these liposomes with ligands all over. Not all of them are going to be active in binding to the surface. There's only going to be a small fraction of them that are active for binding to the surface. So here is a molecular dynamics type calculation from Vladimir Torchilin's group showing the probability of existence at different lengths for polymers. And this is a reduced parameter that is proportional to the molecular weight of the polymer. And the idea being that the larger this parameter gets, the longer the polymer molecular weight, and the larger the fully extended length. Notice that these things have a relatively flat probability of existence until you hit essentially this cutoff dimension and it drops off like a rock. And that's the fully extended length that we consider in the calculations. When you put that in, what you determine is that there are two crucial parameters. One is this active area of the liposome. So this is the fractional surface area of the entire liposome that is actually active for binding to the cell surface. And there's this radius of the area of influence on the cell surface. So for example, this receptor is outside that radius of the area of influence and cannot bind to this liposome. It's only these that are within the area of influence that can bind to the liposome. So you can calculate using relatively simple geometric considerations the active area of the liposome that I've plotted here as a percent of the total surface area of the liposome versus the molecular weight of the tether. And what you can see here is that the larger the liposome gets, the smaller the percentage is. So for a 25 nanometer liposome, you could potentially have as much as 90% of the liposome area actually being active. It's not a very practical situation because at 25 nanometers, there isn't a lot of drug you can get into the liposome. So let's take a more realistic situation around 120 nanometers or so. But you can still get, if you use very long polymer chains, you can get as much as 50% of the liposome area actually being active. More likely, you're going to be down in this 10 to 20% range. Similarly, you can calculate the area of influence on the surface of the cell as a function of peg molecular weight for different liposome diameters, and it has this nice straight line behavior. The reason I put that up there is I wanted to compare those dimensions on the cell surface with the sizes of features on the cell surface, so caveolae and clathrin-coated pits, and lipid raft microdomains, which are very common in the case of receptors that are phosphatidyl inositol anchored. These all have dimensions in this 50 to 100, maybe 150 or so nanometer size range, which compares quite nicely with the radius of the area of influence for polymers that are between, shall we say, 2,000 and 5,000 or so in molecular weight, which are the most common ones we're going to use. So this is the basis of the calculation that says for most of our liposome carriers, one liposome carrier is going to fit on one pit. And it's not really going to reach over and grab either a different caveolus or a different pit. Of course, when you get to very long molecular weights, you can start reaching over from one pit to the next pit and have binding with multiple pits. The question that we need to ask, though, when that happens is binding of a drug carrier to the cell surface by itself is not sufficient. The drug needs to be internalized into the cell before it can be effective. So if you take the case of a chemotherapeutic drug like doxorubicin, positioning the drug on the outside of the cell by itself is not very useful. It needs to get into the cell, right? Now, if a liposome is anchored to two separate clusters on the surface of the cell, and both these clusters are essentially going to try and internalize whatever is anchored to them, what happens to the liposome? It's anchored to two different clusters. It's probably going to get torn apart, or in some fashion, one of the tethers is going to get pulled out of the lipid bilayer, and it's not very useful. So there is a fortuitous optimization that has gone on in picking liposomes that are in this size range, so they can anchor to one internalizing mechanism and be dragged into the cell as a result. So the status of the current model is we have stealth liposomes with ligands. We've taken liposome size into account. We've taken tether length into account. We've taken receptor distribution on the cell surface into account. And it turns out we've also accounted for saturation in the uptake process. And I'll talk about that a little later on. But at a very high level, for example, we work with folate-based targeting. So we've got liposomes that have folates at their here. They bind to the cell surface. They get internalized. Pretty soon, the cell says, I've had enough folate. I don't need any more. And the internalization rate based on folate receptor binding drops. And you need to take that into account in order to be able to fit the data that you see. Okay. I want to talk a little bit about the different classes of receptors that we can target. And I've classified this in a couple different ways, one based on the internalization pathway and the other based on distribution. So the folate receptor, for example, is 100% clustered. There are no free folate receptors on any of the cell types that we have looked at. They're all in clusters. A number of receptors, however, are not so cooperative. They have clusters as well as a random background distribution of receptors. And so if you're targeting one of these, it becomes quite important to take into account the fact that the cluster is likely what is going to internalize. The free receptor needs to be recruited into a cluster first before it can participate in an internalization pathway. The internalization pathways by themselves depend on how the receptors are located on the surface in caveolae or anchored to GPI or in clathrin-coated pits, and there's classifications available for all of these. Again, going back to the internalization of whatever you anchor, if you're using folate, you'd really like to pick ligands that all fall into the same mechanism Otherwise, you're likely to end up binding to different features on the cell surface. Okay, so in order to build this model, we first started modeling our experimental system, which was done in tissue culture in wells. So here's a cell monolayer on the bottom surface of the well. There's a liposome suspension that is in contact with it. So mathematically, that reduces to simply diffusion of liposomes from the bulk to the immediate vicinity next to the cell surface. And we account for that by a simple diffusion constant. It turns out we can do that, and we don't have to worry about all the depletion effects here because the system does not get depleted. The number of liposomes that we put in is so large that there's only less than 1% that are actually bound to the cell surface at any time. And so we can lump all the diffusion down into one constant, which gets multiplied by a concentration term. These liposomes are then going to react with clusters of receptors on the surface with a forward and a reverse rate to form a liposome that is attached to the surface through one bond on the surface of the cell. That liposome that is bound with one bond can then form a second bond and form a liposome that is attached through two bonds. And obviously, this process can go on. It's a population balance type model, and it has the same rate constants forward and reverse as the initial binding. The liposome that is bound to the surface can also internalize into the cell, and so that's another flux pathway that results from the bound liposomes. So here's both of them together. Ultimately, what this leads to is a reaction network that looks like this. You've got binding to form a N-bond liposome on the cell surface, which can be internalized, or it can form an N+1 bond liposome. And so you can think of this as a population balance model with depletion, which is a fairly classical set of mathematical models for this type of system. What that reduces to in terms of equations is a number of ordinary differential equations, and I'm not going to go through every term in this mess for you. This is simply the family of the population balance terms. So each x1, xi through xn are simply the singly bound and the multiply bound liposomes on the cell surface. And then the other species that are not necessarily bound are all referred to by bulk concentrations, and here are the ODEs governing those. You can solve all these together very conveniently using any initial value problem solver. We started out doing this in MATLAB at one point. Now we use our own Fortran code for this now. But at the end of the day, once you solve that as a kinetic model, and then you find the equilibrium levels. Here is data from Phil Lowe's group, who was at Purdue at the time. And this is liposome binding to KB cells at 4 degrees centigrade. And what happens at 4 degrees centigrade is that the internalization rate is dropped virtually to zero. The cells do not internalize anything at 4 degrees. They simply bind. And we can match the binding results almost exactly, provided we put in the diffusion constant. In the absence of the diffusion constant, we get a very rapid saturation, and it doesn't look anything like the data at all. Incidentally, if you calculate out using the diffusion coefficient for this size liposomes and the surface area, you end up with an overall rate constant that is almost exactly this number. So we were very happy with that value. We had to set the internalization and externalization rates to zero, of course, because there was no internalization. So the obvious take-home lesson from this, by the way, is for those of you who do microtiter plate or cell culture type experiments and uptake, you have to agitate those systems. You can't just leave them static, because if you do, you're diffusion limited. And what you're likely seeing is not a trend based on binding, but more likely a trend based on mass transfer limitations. So our experiments, we actually agitate the plates, and we have a much higher diffusion rate constant than this. But anyways, we can fit this exactly. Phil Lowe's group also did experiments at 37 degrees where liposomes are internalized as well as bound, and we can match that data perfectly well too. It turns out that in this case the diffusion rate is slightly different because at a higher temperature the diffusion coefficient for the liposomes is higher. Okay. There's also a component for regulation of the folic acid uptake, but that's not so clear in this case. I'll show it to you in data where the downregulation is much more obvious. Okay, for our own experiments, we've constructed folate conjugates that we can post-insert into liposomes, and I'll show you exactly how that is done. And a remote loading of doxorubicin into the liposomes. How much time do we have? We're running out. Okay, so I'll go relatively quickly here. Okay, so we make our conjugates by actually a relatively simple carbodiimide chemistry, linking an amine to the folic acid and form this species. An issue that we had to deal with was if we were looking at multiple ligands on our liposome surface, and for example, we were looking at transferrin and folate, it turns out that they are very different in size. Here's a cartoon of the folate molecule with respect to the transferrin molecule. They're very, very different in size. And in order to present both these ligands to the cell surface at exactly the same place, we need to put these things on relatively short tethers and the folates on very long tethers. And so one of the things that we've recently worked out is a standard chemistry to be able to do this. And we do this using PEG 3350 building blocks. And so this is, I guess, a homoblock copolymer approach that we use. And so we start with a DPPE with a 2,000 molecular weight PEG and then hydroxysuccinimide of that. And we can add any number of these 3350 folate amine groups to that. And so the reaction of these two together is going to give you a DPPE with a PEG 5350, which is the addition of these two, plus the folate. Okay? And so we can continue this any number of times in order to build a longer and longer chain at the end of the DPPE. We also pull up a neat trick in putting the ligands into our liposomes. We preform the liposomes and then we add micelles of the ligand conjugated lipid and they simply insert into the liposome. The advantage of doing this is that we can very precisely control the number of ligands on the outside of the liposome. We load the drug into the liposomes using a remote loading technique. Basically, we put ammonium sulfate on the inside of the liposome initially. It dissociates out to form free ammonia, which leaves the liposome because it is a neutral molecule and can diffuse out. And you exchange the doxorubicin, which is on the outside of the liposome, in, and it precipitates out as the sulfate. And this is an extremely efficient process, and we can load 100% of the doxorubicin this way. Cell culture details, okay. So we did this on 3 different cell lines. KB cells, which are positive control, I guess they overexpress folate. A C6 glioma, and an E9 cortical cell line, which expresses 0 folate receptors. And the reason we did this was we really wanted to see if we could differentiate between the C6 and the E9 cells, because that's pretty close to the situation that you would be looking at in a glioma, where you'd have tumor cells right next to other neuronal cells. And clearly, we can differentiate them in terms of DOX uptake quite nicely. Of course, the positive controls do a lot better. We've modeled this mathematically, and we've modeled this downtrend also quite nicely mathematically. Here are a number of other controls that we did in order to make sure that the binding was actually folate mediated. So we were able to inhibit the binding by adding a free folic acid. And what is the other one here? Okay, so, and we also did this in co-culture. Rather than have these in separate wells, we had both cell types in the same well, and so we were incubating in the same medium. And again, we can see the same enhancement for the KB cell line. Okay, so if you go back to the KB cell uptake data, it turns out that in order to have the same number of cells exposed to the medium, Justin, who did these experiments, needed to use different concentrations of liposomes. So in order to fit this data, I really need to put in two different concentrations of liposomes, 5 nanomolar and 7 nanomolar, and those are these two lines. And once you introduce the downregulation of folate uptake, we can also predict this reduction in the uptake as a function of the number of ligands per liposome. So what the cell is doing is it's internalizing based on the number of liposomes that are bound. And when it gets too much folate, it's saying, okay, I've had enough. I'm not going to internalize nearly as many anymore, which is why you get a reduced number of liposomes bound. Notice, however, that because this is a large number of folates per liposome, even though fewer liposomes were internalized, more folates have been internalized, and that's why the cell has been saturated. So if you plotted this in terms of folates internalized, this would be a flat curve. Okay. Also notice that our diffusion rate is substantially higher. It's an order of magnitude, more than an order of magnitude higher than it was in Phil Lowe's experiments. That's because we routinely agitate our plates. Okay. So what? I always ask my students this, what's the big deal? We've done a lot of this work, and then what? We can predict the binding of liposomes and the uptake of contents into cells. We can optimize targeting parameters, so we can program into our model how long the polymer tethers need to be for a given ligand size. It's a relatively general model. It only looks at binding and internalization, so it is not specific to cancer therapy. We can use the same things for binding to various other sites, inflammation sites, and plaque, and so on. The model is also suitable, and the platform technology that we have developed is also suitable for both therapeutic delivery and contrast delivery. In the future, we're going to look at overlapping clusters. That does tend to happen. That's not accounted for in our model. We have to put in the lengths of the non-ligand tethered pegs. How do they affect the area of influence? Because they tend to make the length distribution of the ligand tethered, the tethered ligand pegs longer. We have to look at ligand valency, of course. And the next generation really is what Ravi Bellamkonda and I call the multiple ligand system. And I think here's a cartoon of that. So the idea that we're going after here is we've had this long-standing interest in the recognition of surfaces, and how do you recognize a given, how do cells recognize surfaces in the body? For cancer therapy, people have always looked for this one unique receptor and said, if you can target that receptor, then you can get your drug to the tumor. Unfortunately, that one unique receptor has been somewhat elusive. You can find unique markers that are intracellular, but it's very rare to find a marker that is expressed on the outside of the cell. And ERB2 is one of the few that are reasonably unique to breast cancer, for example. So the approach that we've taken is to look for more than one ligand. Let's not restrict ourselves to one ligand targeting one receptor, but maybe the cell surface has some unique fingerprint that is a combination of receptors. So can we tailor our drug carrier with many different species of ligands on the outside, which would match up with the fingerprint of the receptor profile on the cell surface? And we've actually modeled that, although I haven't shown you the data today, and shown that with two ligands, we get roughly 1,000-fold enhancement in binding over a single ligand system. And so the next step, obviously, is to fabricate those things and try out a multiple ligand experiment. Okay, I'll take questions, and I'll leave you with the 3D volume movie of a rabbit heart that we got using our long circulating contrast agent. Thanks.
Thank you. We have time for a few questions.
because they're stunned.
I guess I'll start off with one. Not all cells start off with receptor clusters, but they cluster after binding as a way to
recruit.
So what types of cells does this include?
Okay, we've just not included receptor mobility and receptor recruitment into the calculation as of now. GPI-bound receptors are likely to be fairly mobile. It's not clear what the signaling pathways are that cause the recruitment. At least they're not quantitatively understood. Some of the reactions may be understood, but the rate constants for the signaling are definitely not understood as of now. And that's the primary reason why we have not included it in the calculations. Mechanistically, it's actually quite simple to put into the calculation. And as soon as we know what those reactions are, we'll simply plug them in. Yeah. Mark?
You'd identified 6 hours as a target to keep your contrast going. I was wondering, in what scenarios would you need to monitor using some imaging technique for that long?
Anytime you want to look at processes that take place over that time is the obvious answer. And that does not have to be a biological process. It could be something as mundane as workflow in a radiology clinic. It might be easier for them to simply inject at one time and get the scan later on. But for example, the tumor detection example that I showed you, you see peak enhancement of the tumor contrast over the blood at 3 to 4 hours after injection. So anytime you want to see things leaving the blood pool and then going elsewhere, that's when you would really want that long circulation time.
On the multi-tether liposome, the model predicted a 1,000-fold increase using 2 separate. Was that independent of the identity of the pair?
No, of course it's dependent on the identity of the individual ligands, and so we plugged in on rates and off rates for particular ligands in that calculation. A particular calculation we used, relatively naively, we used folate and transferrin. It turns out that's probably not a good model to use because there are different classes of receptors and internalization is not likely to be highly efficient. And so, yeah, we'd have to revise that. Unfortunately, those binding constants are not easy to come by either, so we pull them at rare intervals from the literature. Yeah. But the short answer, it's very dependent on the ligand-receptor combination. Yeah.
Thank you.
All right, thanks.